34, we're doing renal on diabetic nephropathy. I'm Louise and I'll be looking at pharmacology.
I'm Kerryn and I'll be doing pathophysiology.
I'm Chloe and I'll be doing the complications related to diabetic nephropathy.
And I'm Maddie and I'll be doing case presentation and we'll all be doing nurse management.
Our patient's name is Phil Nephron. He is a 78-year-old single Caucasian male. He is 183 centimetres tall and weighs 112 kilograms, with a BMI of 33. He is a retired train driver who wears glasses and is an ex-smoker. He has no known allergies. Phil Nephron has a history of coronary heart disease. He was diagnosed with type 2 diabetes mellitus at 50 years old and he has had a TURP. There is a family history of coronary heart disease and lung cancer on his father's side. Phil Nephron's baseline observations are blood pressure of 165/84 before medication and 135/78 after medication. His heart rate is 88 with a respiratory rate of 16. His temperature is 36.7 and he has a Glasgow Coma scale of 15. His blood glucose level is 7.2. Phil Nephron's clinical manifestations. It is important to note that the symptoms of kidney disease are not always specific. In most cases, the first symptom of kidney disease is fluid buildup, followed by microalbuminuria or small amounts of protein in the blood, which will change to macroalbuminuria or large amounts of protein in the blood as kidney disease progresses. Other symptoms include hypertension, decreased GFR rate, decreased sleep, often caused by increased urination at night, poor appetite, upset stomach, waste products in the blood, weakness and difficulty concentrating. Phil has presented to emergency with a sudden decline in renal function. Upon assessment, it is found that Phil has a decreased GFR rate of 20 and his blood sugar levels are elevated. A medication review is required to assess the possibility of new medication being prescribed by the doctor, with discontinuing any medication that may become toxic with the decreased GFR rate. Upon presenting to emergency, a set of observations were conducted with the following results. A blood pressure of 140/80 after taking medications while still waiting for effects, heart rate of 95, a respiratory rate of 18, a temperature of 36.9, a Glasgow Coma scale of 15, a blood glucose level of 12.1 and a GFR of 20.
Diabetic nephropathy pathophysiology. Hello Mr. Nephron, my name is Kerryn and I will be your nurse for today. I would like to explain to you how hypoglycemia plays many roles in contributing to the pathophysiological changes within the kidneys, including the activation of angiotensin II and atherosclerosis resulting in hypertension, and how these processes contribute to the eventual loss of kidney function. Sit back and relax. Now let's zoom in here and take a closer look at the nephron. The nephron has a cup-shaped end called the glomerula. It is in here that blood begins to be filtered. In these tubules is where filtration, selective reabsorption and secretion occurs. The glomerulus has three filtering layers: the capillary endothelium, the basement membrane and the epithelium. It has an afferent arteriole that flows blood through into the glomerulus and an efferent arteriole where the blood flows out after filtration. Angiotensin II induces efferent vasoconstriction and increases sodium reabsorption in the tubules. This increases your blood pressure. With a higher fluid volume and pressure going into the afferent arteriole, and with vasoconstriction on the efferent arteriole, the pressure within the glomerulus is increased. Filtrate fluid is forced through the glomerulus. This added pressure causes the mesangial to expand. Proteins such as albumin are now able to get through. This is why your urine showed a positive result for albumin. The damage that is caused to the mesangial activates an inflammatory response, sending macrophages and T cells to the site. The mesangial thickens through fibrosis, which is scarring. Filtrate is now unable to get through. This is why, Mr. Nephron, your urine is reduced. We can also see this on the glomerular filtration rate of 20. Remember when we talked about the efferent arteriole? Well, not only does it cause increased pressure in the glomerulus, but it also prevents oxygenated blood flow to the rest of the nephron. Without an adequate blood supply, the nephron becomes ischemic. Mr. Nephron, this is what is occurring in your kidneys. Unfortunately, once a nephron dies, it no longer filters, and eventually the blood within your body becomes toxic. Do you have any questions?
Pharmacological interventions. National Safety and Quality Health Service Standards 4 and 5. Before we look at the medications, it must be noted that a registered nurse does not prescribe medication. Only doctors, dentists, optometrists, midwives and nurse practitioners have the authority once they've been approved under the National Health Act 1953. Prior to administering any medications, the nurse must inquire if the patient has any allergies, and particularly allergies to medication. Double check patient details and UR number. We must perform all vital signs, and the nurse must follow the 6 rights of medication administration, which are right patient, right dosage, right route, right drug, right time, right documentation. Some facilities as well may further their policy, adding that we must have the right education for the patient, explaining all side effects, adverse effects of medications. We must undertake the right assessment, which includes vital signs and consulting with your patient. And the patient also has the right to refuse. The first drug Mr. Nephron is taking is called irbesartan, and the trade name is Avapro. Its classification is an angiotensin II receptor blocker, ARB, antihypertensive. The action is to antagonize angiotensin II receptor blocker, stopping the angiotensin II chemical and receptors binding, resulting in vasodilation of the blood vessels and a reduction in blood pressure. ARBs are prescribed to reduce blood pressure and specifically slow progression of kidney disease by decreasing protein excretion in hypertensive diabetic patients diagnosed with nephropathy. Adverse effects include hyperkalemia, hypotension, dizziness, headaches, tiredness, back pain, myalgia, nausea, abdominal pain, and some rare adverse effects can be a rash, pruritus, and peripheral edema. The contraindications in patients with hemodynamic significant bilateral renal vascular disease, severe stenosis, and just one kidney. The second drug is furosemide, which is trade name Lasix. It's a high-ceiling loop diuretic. Lasix inhibits the reabsorption of sodium, potassium, and chloride in the proximal and distal renal convoluted tubes, but mainly in the ascending loop of Henle, resulting in increased urination. It is used in patients with a diagnosis of cardiac, hepatic, renal, and pulmonary edema, where other diuretics were ineffective or unsuitable hypertension. Loop diuretics are recommended for patients with a glomerular filtration rate below 30 mL a minute. The adverse effects are hypovolemia, dehydration, dizziness, headaches, fatigue, confusion, hypotension, hyperglycemia, electrolyte imbalance, impaired glucose absorption, hypokalemia. When combining with an ARB, furosemide should be withheld for 24 hours while the ARB is introduced at a low dose to start to avoid hypotension. Insulin. There are a few different insulins on the market available to patients. These include a rapid-acting insulin, which works in approximately 15 minutes and lasts for an hour. A short-acting insulin, which works within 30 minutes and lasts for about 2 to 3 hours. Intermediate-acting insulin, which starts working around about 2 to 4 hours and can last up to 12 to 18 hours. And a long-acting insulin, which takes a few hours to start working, but lasts for 24 hours. The long-acting insulins can usually be combined with a rapid or short-acting insulin. So insulin is released in the body by the beta cells located in the pancreas in response to increasing levels of glucose in the bloodstream. Insulin delivers glucose to the body's organs and tissue for cells to absorb. Insulin regulates blood glucose level, with storing glucose in the liver to be released when glucose levels become low. Two main types of insulin prescribed for diabetes sufferers are bovine insulin, derived from cows. This type of insulin is becoming rarer and will be found to be used in the older patient who has not switched to the more recent human insulin. Synthetic human insulin is currently the most commonly used insulin. Some adverse effects can include hypoglycemia, edema, visual impairment, arrhythmia, pain, swelling, hives at injection site. Some rare effects can be insulin resistance, peripheral neuropathy. Drug 4, atorvastatin, trade name Lipitor. It's a class HMG-CoA reductase inhibitors, lipid-reducing agent. Statins reduce levels of low-density lipoprotein in the blood. By inhibiting the HMG-CoA reductase, in turn reduces cholesterol synthesis and increasing LDL receptors, resulting in lower levels of LDL. LDL carries cholesterol from the liver around the body to deposit it in tissue, which is then associated with the development of atherosclerosis. Adverse effects include constipation, flatulence, abdominal pain, nausea, headache, insomnia, pruritus, rash, and some rare effects are myopathy and hemorrhagic stroke. Contraindications with Lipitor is avoid large quantities of grape juice as it increases the serum atorvastatin levels. Avoid erythromycin, clarithromycin, antifungal agents, verapamil, diltiazem, and amiodarone, as there is an increased risk of myalgia and rhabdomyolysis, which is a breakdown of damaged muscles. Also possible increased levels of digoxin, causing toxicity.
Edema is caused by fluid retention, which results from the kidneys producing less urine and filtering less fluid. Nursing management involves a strict fluid balance chart and restricting fluid intake to minimise fluid retention. The nurse should also educate Phil on the importance of restricting his fluids. Hypertension results from an activation of the renin-angiotensin-aldosterone system that increases blood pressure. Nursing management includes educating Phil on lifestyle choices, including dietary modifications and exercise, to reduce the narrowing of the arteries that can result in hypertension. The nurse must monitor Phil's blood pressure to assess the effectiveness of interventions and educate Phil on his medication. Anemia is a common complication of diabetic nephropathy. It reduces oxygen flow to the kidney, quickening deterioration. Nursing management includes monitoring iron status and correcting the underlying cause for iron deficiency. End-stage renal failure is the progression of diabetic nephropathy. The kidneys can no longer remove waste or perform regulatory functions. Nursing management involves alleviating pain and discomfort and monitoring vital signs to identify deterioration. The nurse is also required to educate the patient on appropriate choices for continuing care, for example, dialysis, or making the patient comfortable. Dialysis is a complication of diabetic nephropathy considered when glomerular filtration rate decline, and Phil will be experiencing symptoms of fatigue and nausea. Nursing management includes assessing vital signs to determine how the body is coping, administering medications, and patient education. National Safety and Quality Health Service Standard 9 recognises responding to clinical deterioration in acute healthcare is particularly important in the case of Phil. His condition and treatment is determined by the rate of deterioration. To achieve this standard, the nurse should use charts to record observations that include parameters of normal to specify when to escalate care. In Phil's case, a system for preparing and documenting his advanced care plan, such as dialysis, should be in place.